Hi, I'm Professor Beverley Hunt from London. I have no conflicts of interest, and I'm here today to talk to you about COVID 19, thrombosis, and the use of anticoagulation. Before we start, I wanted to touch on a few concepts in thrombosis and hemostasis that are really relevant to COVID. The first is that the coagulation system evolved as an effector system of the immune response. So we would expect to have thrombosis in areas of high inflammation. And indeed, when we look at things like vasculitis, we expect to see thrombotic events, especially in areas of high inflammation, and we treat that with some form of inflammatory treatment. For example, with Behçet's, we'd use biologicals rather than anticoagulation. And lastly, we're dealing with severe hypoxia, and hypoxia is a profound stimulator of thrombosis. The hypoxia inducible transcription factors will lead to a prothrombotic state by the HIF gene inducing binding to tissue factor and the PI1 genes. So, just a quick run through COVID 19 pathogenesis. We know it's binding to the ACE2 receptors on pulmonary endothelium and epithelium first. And we also know that it's binding to macrophages and also adipocytes. Most people, thankfully, get asymptomatic infection, but but the problem is 5% are getting COVID pneumonia and becoming hypoxic. And we know in these patients, we've got a profound inflammatory response in the lungs with the cytokine storm and macrophage activation. And we're admitting these patients to give them oxygen. The other effect of this amazing inflammatory response and the cells involved is that we are getting a prothrombotic state due to the effects of IL-1 and IL-6. And really, the question is, are pre-existing inflammatory states, those present in obesity and with increasing age, the reason why those age groups don't and those people with those factors don't do so well? Just to remind you that obesity is associated with the adipocytes changing their phenotype. They produce large amounts of cytokines, and one of their effects is to make the blood more sticky, so increase levels of fibrinogen and drop levels of others and increase PI1. So when we look at COVID, we know that when we get the infection, patients are asymptomatic. Unfortunately, we're hospitalizing many because of the pneumonia. And we know that if you hospitalize patients, we've got increased rates of venous thromboembolism up to 90 days post-discharge. And the other thing about COVID that we're learning is that we're having late sequelae. So some people have COVID toes, and we have the massive inflammatory response seen in a few children. So we've got some risk factors, particularly with hospital, but we mustn't forget the fact that if you have immobility, you've got increased risk of VTE. And what's becoming very evident to me is that there are quite a few people who clearly had pneumonia at home or in a care home and didn't get admitted to hospital, and some of them are having VTE. So this is the traffic lights for admission to my hospital. Your level of hypoxia determines where you go. Obviously, severe hypoxia means mechanical ventilation. We've looked at our first month of intensive care patients who survived, and this really summarizes their levels of fibrinogen, D-dimer, procalcitonin, and ferritin and CRP. I'd like you to note that for D-dimer, we've got a logarithmic scale as we have for procalcitonin. So these patients are profoundly prothrombotic, and fibrinogen, D-dimer, procalcitonin, and ferritin are all running together as part of acute phase proteins. Our median fibrinogen was about 7 or 8, but we have seen them as high as 14, which is really extraordinary. And of course, these really high levels of D-dimer. So this isn't a DIC, but acute inflammatory response. And of course, what's going on in the lungs is that we're also getting local inflammation with local thrombosis, which we are calling immunothrombosis. And this is due to activation of endothelium and macrophages. The neutrophils are probably playing a large part too due to netosis. So, what are we doing for our patients? Well, we know that if we give thromboprophylaxis to medical patients, and this is a summary of all the trials at the turn of the century, we get a risk reduction of rates of venous thromboembolism by about 50%. And since the beginning of COVID, we have been giving thromboprophylaxis across Europe and North America. And the question has been raised, is this really enough? And the other problem we've got is we know we have high rates of VTE in critically ill patients. It's not clear what the underlying rate is in critical care patients these days. The last data we have again goes back to the 2000s, and one wonders with the increasing age of patients and complexity of their illness whether rates aren't higher than the 29% quoted at that time. And then we have good literature to show that using low molecular weight heparin and unfractionated heparin reduces the risk of hospital associated VT by about 50%. This really good systematic review looked at over 7,000 patients and showed reductions of DVT and PE of 50%, though no difference in bleeding or mortality. And the question has been asked by Lim, which is better, low molecular weight heparin or unfractionated heparin? And the answer is low molecular weight heparin. It does further reduce the risk of pulmonary embolism over unfractionated heparin. And so we have this great, well, interesting data from China very early on, where they looked at patients and they gave some of them heparin. Now, why did they give them heparin? What type of heparin did they give them? What was the dose? We really don't know. And this is typical of one of the early COVID publications, in that you would never have accepted it if it wasn't related to COVID. But what's clear from this hospital is they weren't using routine thromboprophylaxis, and they gave some of their patients heparin and they reduced mortality. And since that time, we have had so many papers come from Europe and North America looking at rates of VTE. It's like a snapshot of VTE rates in patients early on during their ITU stay. And what became clear, especially the paper from Clock, is we were seeing high rates of what we called venous thromboembolism. And the Clock paper mentioned that 14% had VTE as defined by CTPA and ultrasound of the legs. But when actually you look and break down what's happening, most of the PE are subsegmental, and their underlying rates of VTE wasn't so high. So we've got Middledorp again. If we look at her data from Amsterdam and we look, here we go, at the PE, they are all segmental or subsegmental. And we think in London that that is actually immunothrombosis, local thrombosis seen within areas of high inflammation. So we've looked at our first 66 patients, and if we discount those small areas of clot and say they are immunothrombosis, our underlying rate of VT is about 5%, which isn't so bad. And at the time, we were using standard thromboprophylaxis. So really, this summarizes all of the papers looking at rates of VTE during ICU admission, not taking them out to 90 days. So if we look at the rates and the percentages, up to 37%, but one does suspect that many of them are counting immunothrombosis as VTE. And then we've got this other question of we've got this incredible prothrombotic state. We know with COVID, patients have extended critical care stays. Surely they will have a high risk of VTE post discharge. Because if we look at a hospital associated VTE, we know that 60% occur post discharge. So we've got a summary here of all of the trials looking at post-discharge thromboprophylaxis in medical patients and include critical care patients. And we know that if we give low molecular weight heparin, we get a further reduction of VTE, but unfortunately that benefit is lost by increased bleed rates. And it's only with the use of etrixaban and selected patients having rivaroxaban that the benefit comes through and the risk of bleeding is minimal. So if you look at the APEX study, just taking the highlights from it, this is a very short talk, we know the highest risk patients are those with high D dimers, goodness, they're high in COVID, and those with intensive care stays. So we should argue that maybe they should have extended thromboprophylaxis. But really, the papers looking at rates of VTE post discharge are only coming through. We have one paper from King's, and they had no rates of VTE post discharge. And I'm reviewing others at the moment, and I know that that's rather unusual. So, coming to the end, we have many unanswered questions about thrombosis and thromboprophylaxis. We have excellent guidance from experts, which at the moment don't require updating because we need more research. For us at Guy's and St Thomas's, we had many doctors coming to do ITU care who hadn't done ITU care before, and we produced this handout card for them about how to manage the hematological problems in the patients, and you'll see we put thromboprophylaxis in there. What we really need is research. And we have the platform trials and many randomized controlled trials going on across the world looking at different doses of anticoagulation. The big question is, if we give more anticoagulation, will this further reduce the rates of venous thromboembolism that we're seeing? Thank you very much for listening.